Hello, I'm Dr. Jack McDonough, Chairman of the Advisory Board of the Henry R. Winkler Center for the History of the Health Professions at the University of Cincinnati College of Medicine. The Winkler Center is a medical archive, library, and exhibits gallery that encourages visitors and researchers to explore and examine the Cincinnati area's rich medical history and discover the people who have contributed important advances in medicine, nursing, and the pharmaceutical sciences. One of the real gems of our collection is the Video Oral History Program. The histories and stories that we have collected from many of these remarkable pioneers are fascinating. We wonder sometimes how they made their discoveries, what pushed them to become the leaders in their fields, and even what their lives were like outside their offices and laboratories. Today, we are going to interview Dr. James Helmsworth, a nationally and internationally known cardiovascular surgeon and researcher who has made enormous contributions in the field of cardiac and thoracic surgery. Dr. Helmsworth graduated from the University of Pennsylvania Medical School in 1939 and served a 2-year internship at the University Hospital of Pennsylvania in Philadelphia, followed by a surgical residency here at the University of Cincinnati under Drs. Mont Reed and Nick Carter. In World War II, he joined the Army and requested overseas duty, and he served 32 months of overseas time in the Far East. In the military, he was assigned to the 86th Field Hospital, and after training, landed on Okinawa on D+30 with active combat taking place. At the end of the war, he spent time in Korea and Japan. Returning to Cincinnati after the war, Dr. Helmsworth completed his residency and began performing cardiac surgery at the Children's Hospital. One of the highlights and great contributions of Dr. Helmsworth's career occurred in 1951. Working with cardiologist Samuel Kaplan, chemist Leland Clark, PhD, and Frank Golan, the team developed the world's first functional and practical heart-lung machine, located at the Cincinnati Children's Hospital Medical Center. One of the prototypes is located in our Winkler Center. Joining me today to interview Dr. Helmsworth is Dr. John Flagey, distinguished cardiac surgeon and professor of surgery at the University of Cincinnati. Let's join them as we talk about Dr. Helmsworth's fantastic career. Thank you. Well, Dr. Helmsworth, it's a pleasure to have you here today, and we'll be interviewing for our audience. Dr. Helmsworth is a renowned cardiovascular surgeon and professor of surgery here at the University of Cincinnati. And my co-interviewer today is Dr. John Flagey, who is also a very distinguished cardiac surgeon and also a professor of surgery here at UC. Dr. Helmsworth, you've had an amazing career as a cardiovascular surgeon and educator spanning over 70 years. You were born in Jamestown, North Dakota on March 15, 1915, which means at your next birthday you'll be 97 years of age.
True.
And your father ran a grocery store.
Yes, that's true.
And you were honored to be able to work in it from the age of 10.
Yes, that's right.
Can you tell us where Jamestown, North Dakota is?
It's in the eastern part of the state of North Dakota, on a line straight west of Fargo, North Dakota. And half the distance between Fargo and Bismarck is located Jamestown.
How many, what was the population when you were there?
About 7,000.
Oh, so it's a pretty good-sized little town.
Well, for North Dakota,
Yeah.
not bad.
Right. Well, can you tell us what drove you to go through, you went through high school obviously, to go to the University of Pennsylvania College of Medicine?
I went to college in Jamestown, North Dakota.
Oh, you did?
That's a small Presbyterian-based college. I think there were about 500 students in total when I was a student. I graduated in 35, and I wanted to go to medical school, and there wasn't a school at the University of North Dakota. They offered the first 2 years of training, the first 2 years of medical school, and after that, you had to transfer. I thought it would be better, for many reasons, for me to go to where I could get 4 years of medical school in one place. And I thought that since I was leaving home, I would like to continue my education in another part of the country. So the East Coast was attractive to me for that reason, mainly for that reason, and the University of Pennsylvania had a very good reputation, and I had known one or two men who had gone to Wharton, the financial school, and I decided to apply, therefore, and was successful.
Mm-hmm. And then you did your internship in Philadelphia as well.
Well, yes, the practice with respect to internships was different in those days, I think, from what it is now. In that part of Pennsylvania, the practice was usually to have 2 years of internship.
Mm-hmm.
I think that would correspond to what is called PG1 and PG2. I had my internship at the University Hospital, and it was of 2 years.
Mm-hmm. And why did you pick the University of Cincinnati with so many schools on the East Coast? What drew you to Cincinnati?
The University of Pennsylvania, and my internship at the University Hospital, gave me a good view of training in surgery. Their program was not approved, as a matter of fact, not approved by the American Board of Surgery for training in general surgery. So for that reason, I wanted to look elsewhere for training in general surgery. The reputation that Dr. Reed had established for training in general surgery was well known, even in Philadelphia, which certainly wasn't Dr. Reed's home area. And for that reason, I applied. I wasn't accepted at first. A classmate of mine named Singleton was accepted, and Singleton also applied to the University of Michigan. I don't remember the name of the chief of the service at the University of Michigan at the time, but Singleton's father was the chief of surgery, professor of surgery at the University of Texas at Galveston, which gave him a little more power than my background as a grocery clerk, I'm sure. Anyhow, Tex had been accepted here in Dr. Reed's program, and then he was accepted also at the University of Michigan. So he decided to go to the University of Michigan, which opened up a slot here, I guess, because it wasn't long after that I heard that I had been accepted.
Oh.
I think I was second choice to Albert Singleton.
And you started your residency here in 1941.
I did.
And Mont Reed was the chief.
Yes, he was.
Can you tell us a little bit about Mont Reed? What kind of a person, educator he was?
Dr. Reed was not your typical general surgeon. He tended to be rather quiet in his manner. He tended to speak only briefly, and I found him rather formal in his attitude toward the residents. When we would walk down the hall, it was always perfectly clear that the chief resident walked with Dr. Reed, but the other residents or interns followed at some distance behind. And maybe this was a carryover from Hopkins, I don't know, and very possibly from the time of Halsted, because we were always told that Dr. Reed was one of Dr. Halsted's favorites because of Dr. Reed's skill as a surgeon. And of course, Dr. Halsted still had considerable influence on the training of surgeons, even at that late time.
Mm-hmm.
Dr. Reed was not in good health, and it appeared to me as a junior that Dr. Reed was quite tired, almost fatigued at the end of a large operation. A large operation might be a radical mastectomy, or it might be a combined abdominal perineal. But it seemed to me that Dr. Reed needed a chair and a blanket thrown over his shoulders and perhaps some extra fluid after he had completed a combined abdominal perineal.
Mm.
He was tired.
And he passed away in 1943.
Yes, he did. He had coronary vessel disease,
Mm-hmm.
not defined in the way we can have it defined nowadays, but he did have a coronary vessel disease and died in his home. He felt more secure in his home. In those days, of course, patients were placed in an oxygen tent, and the maintenance of the temperature and cooling in the oxygen tent could be quite a problem. Ice had to be packed into a chamber in the back through which the oxygen passed and into the tent. And Dr. Reed was not confident that he would be safe in an oxygen tent in the hospital.
Mm-hmm.
So it was arranged for a group of residents to rotate, and we went to Dr. Reed's home and were, if not at the bedside, immediately available, if for nothing else than to repack the oxygen tent with the ice.
Mm-hmm. And as I understand it, his home wasn't very far from here.
Not very. It was over on Bedford Avenue.
Right, yeah.
Yes. Mm-hmm. So a schedule was worked out, and we would go over, one man would go over for 8 hours, and then another man would relieve him, and another man relieve the second. So Dr. Reed was taken care of in that way at home.
Mm-hmm. Now, was he an accomplished surgeon technically? Because some chiefs of service aren't that good.
He was accomplished.
Good.
Yes, it was true. An important thing that always struck me at that age of my career was that he would never use the Bovie unit. Never. So at the time of doing a radical mastectomy, the area around the chest from which the breast had been removed was solid with hemostats. And each one of those had to be ligated with 4-0 silk, you know. He wouldn't use the bovie unit. It was exhausting to stand there as a second assistant and cut the ligatures as he and Ed Schnug, the senior resident, ligated the innumerable hemostats.
I think Dr. Stevenson used to do that even in my time.
I'll bet he did.
He did. When he passed away, did Max Zinninger, that was during the war, was Max Zinninger take over then, or is that when Nick Carter came on board?
It's my impression that Dr. Carter took over then, and that Dr. Zinninger took over when Dr. Carter left the department for a while to go to the Department of Defense in Washington.
John, you had a question about Dr. Carter. You asked me yesterday about why he left the professorship so quickly.
Yes, I was, in reviewing this timeline, it seemed that he wasn't here very long after he came back from the service before he retired. And I wondered what the background of that
I can't give you the background on that, John. I don't know what the story is on that. To those of us who were in training at the time or shortly out of training, it was very much a surprise too, and I don't know what the story is on that.
Well, you mentioned something to me the other day about changes in convalescence with general surgery and the current early ambulation or outpatient surgery for a hernia and more or less the Holmes Hospital method in 1941 or 42.
Well, I was impressed with the Holmes Hospital method because I knew it pretty well. That was one of my first assignments when I came here in 41. Dr. Reed and Dr. Zinninger, the two of them, I remember well, would repair a hernia, an inguinal hernia, on a healthy young man, or a femoral hernia on a healthy woman, and they were kept flat in bed, dead flat in bed for 14 days. Nothing was ever said about leg exercises, you know, or ambulation to at least go to the bathroom. No, they were flat for 14 days. I don't know what it was like when they first stood up after that time, but I would think would have been pretty hypotensive.
Can you recall the incidence of pulmonary emboli in those post-operative patients?
No, I can't recall the incidence, but we were learning to recognize it as a problem.
I'll bet, yeah. And you said that the residents went to different hospitals back in your day. You mentioned the branch hospital, which the younger crowd might remember as Dunham Hospital. And then it's a rotation in California, I believe.
Yes, well, the rotation up to Dunham Hospital was interesting in one sense, and that is that the treatment of tuberculosis was, the surgical treatment for tuberculosis was limited at that time to thoracoplasty. So the residents would go to Dunham and assist Dr. Carter, as a rule, assist Dr. Carter doing a thoracoplasty. Miss Maciel had made some, what I thought were beautiful drawings of the operation. The operation itself was a very destructive procedure, and I can't imagine what it was like must have been like to go through under local anesthesia.
Oh my heavens.
But that was the method of choice at that time in the very early 40s.
And then they started using lucite plombage or something, I recall.
Oh yes, a little later on.
Yeah, with little ping pong balls.
Yes, that's right.
And you mentioned Dr. Glenn Bell at the University of California.
Well, the rotation to California was regarded as a plum, a reward for good work on general surgery here at the old General Hospital. And it was offered as a rule to a man who had been in the program 3 years or maybe 4 years. He was a young man who had established the fact that he had potential. And plus the other fact, and this is just gossip, I never heard a staff man say it, but the other fact was that he was unmarried. The gossip among the residents was that you would not go to California if you were married. And I know that affected 1 or 2 romances, fellows who returned from California and immediately got married thereafter.
Uh-huh.
But the rotation to California was very good from the standpoint of experience. The fellows reported that it was a good educational experience under Dr. Bell's guidance, and all in all, we all of us wanted very much to get to go, but it was limited to one per year.
Well, Dr. Bell actually spent time here, didn't he? Didn't he come and rotate with Dr. Mott Reed?
He may have in the early years.
In the early years,
In
right.
the early years,
Right.
yeah. He may have.
Well, in 1944, you headed off to the Far East. You were inducted into the Army. Can you tell us a bit about that?
Well, Charlie Holzer lent me his car to drive to Dayton, which was the area, which was the unit we went to for induction into physical examination and induction into the Army.
Right.
So I went up there, and not long after that received orders, and my orders were for me to travel to a couple different places. As it turned out, I went to Atlanta to a general hospital for a few months, and then later on I went to Fort Dix for a month or so, and it was at Fort Dix that I received my assignment to the 86th Field Hospital. And we were sort of drawn together as a unit to be labeled a field hospital and put on a troop train and sent across the United States and reassembled in Seattle, where again we saw the people that were to make up our unit, and within a day or two we were on a boat and off to Oahu in the Hawaiian Islands, where we spent a few months practicing being an Army field hospital.
Mm-hmm.
Setting it up and seeing how we would deal with casualties.
And then after that, you went to Okinawa, I believe.
After that, we went as a unit we were on a troop ship that took a long time, move in convoy, as a matter of fact, in convoy, moved slowly, and we ended up on Okinawa. We weren't there very early in the conflict. I think it was D+30 or something like that, 30 days after the initial landing. And there was still conflict, heavy conflict in the southern part of the island, down around the city of Naha, and some conflict up in the very northern part of the island. But where we were centered, it was secure. We were required to guard our own perimeter, but it was relatively safe at that time.
Mm-hmm. But you were seeing active combat casualties.
Oh yes,
Yeah.
oh my yes, a heavy load of combat casualties, yes. And a field hospital in an area of limited size, like the island of Okinawa, received casualties from all the services. We had, well, I should say mainly, aside from Army casualties, we had mainly Marine casualties. And that was about it.
Mm-hmm. And then after the war, you went to Korea and Japan?
Well, our unit was moved to, we were moved as a unit. We were held together as the 86th Field, and we were moved to, on a troop ship. It was an LST, as I remember it now. And we were moved to Incheon, Korea, which is a port city, not far from Seoul, to be sure.
Mm-hmm.
We landed in Incheon and were taken by trucks up to Seoul. And we set up as a station hospital at this time in what had been a Japanese department store. The department store was well, structurally, it was pretty good. The toilet facilities were not good, and the telephone system had broken down. But otherwise, we had 4 walls and a kind of a heating system and good light. So it wasn't bad.
I'd like to back up just a bit. You told me the other day that when you were a resident, you wanted to get overseas duty, so you contacted Nick Carter, who was with the Surgeon General.
Well, that's right. I wanted to join the Army. There wasn't any question about that, but I didn't want to stay in the States. I thought I would like to go where the action was, you know. So I took it upon myself to write to Dr. Carter. I felt I knew him well enough, at least, to make a request. So I wrote to him and told him I wanted to go overseas. I didn't care which direction,
Mm-hmm.
of course, and I guess at that time his office was making up a field hospital, and I guess that's how I got
Ended up there.
into the 86th.
And for the pleasure of asking, you spent 32 months overseas, right?
That's right. Well, that's right. I was in the service 36 months and overseas 32 months, but that was fine.
So you came back to Cincinnati in '47 and finished your residency under Dr. Carter or Dr. Zinninger at that time?
That was still Dr. Carter, yes.
Okay. And when you finished, you wanted to go, I believe you said you wanted to go to Michigan. Tell us about that experience.
Well, I did want to go to Michigan. A couple of things were happening up there. I'll think of his name as this conversation goes along, but there was a thoracic surgeon who was carrying out pulmonary resection in a large number of patients from the various sanitaria in the state of Michigan. So he was doing lobectomies, mainly, every day. And I thought it would be helpful for me in my training in thoracic surgery to go to the University of Michigan. In addition to that, there was another surgeon named Cameron Haight who had reported on the treatment of tracheoesophageal fistula in infants. And this was a startling development. nothing effective had been done for those infants until Cameron Haight was successful in anastomosing the upper pouch and the lower part of the esophagus or stomach and saving the life of these newborn. So I thought it would be good for me to go to a place where this kind of activity was going on almost every week. Certainly for the TE fistulas, it might not be every day, but for the tuberculosis resection, for the lung resections, it was every day. I spoke to Dr. Carter after the residency. I was in Dr. Carter's office, and I asked him if he would give me a letter of recommendation to the chief of surgery at the University of Michigan. I said, I'm interested in the lobectomies that are being done for tuberculosis and the other developments that are taking place up there. And he said, oh no, you don't want to do that. I don't think that's a good idea for you. And well, that was the end of that. I wanted to stay in Cincinnati, and I wanted to stay on the right side of Dr. Carter. And so when he said he didn't think it was a good idea, then there was no further discussion.
No, I'm sure not.
When did you become really interested in thoracic surgery with a view toward making that your career?
Oh, that was when I was in Okinawa, really. I didn't have an opportunity. Fortunately, there weren't many soldiers with severe chest wounds that couldn't be treated without simple chest tubes, you know. Mm-hmm. But there was a thoracic surgeon, and what the Army had called a chest team. I don't know how many teams there were. Certainly not very many in the Pacific. I know there were neurosurgical teams. Well, this thoracic surgeon with a chest team was a fellow named Max Chamberlain. Oh, yeah. And you may have met Max. Max had been in charge of the surgical treatment of tuberculosis at the sanitarium in New York State. He had had some training in thoracic surgery while he was a resident at the Massachusetts General Hospital. Mm-hmm. Well, Max, with his chest team, which involved, I think, one other surgeon, a junior surgeon, and 4 technicians. I think that's all there was to his team. He had set up operation in northern Okinawa, mm-hmm. so that when the island was secure, the Japanese prisoners were gathered together and sent up to the northern part of the island. Well, the Japanese prisoners hadn't been treated for anything. They hadn't been treated for tuberculosis, and many of them had tuberculosis, and they hadn't been treated for hemothorax. Many of them had old clotted hemothoraces with loss of lung function, of course, compressed under that mass of blood and fibrin and all. So Max was doing resections and thoracotomy for clotted hemothorax every day. And I had an opportunity to go up and watch him work. And that impressed me too, and made me think more and more that I wanted to practice thoracic surgery.
Was there anyone here at the time you were a resident who was concentrating on that to any extent?
Well, Dr. Reed had designated Ed McGrath Ed McGrath had gone through the training program under Dr. Reed, and Dr. Reed recognized Ed's brilliance as a scholar, and indicated that he wanted Ed to focus on thoracic surgery and what could be done in treatment of diseases of the chest. Ed was not famous for his ability as a technician, but he was unmatched as a scholar. Absolutely. Brilliant guy. Had tuberculosis himself, was confined to bed for a year, but made a good recovery and had good strength as I knew him. Good strength. And I found him to be a very stimulating mentor.
Well, when you finished the residency here and Dr. Carter said that you were staying, did you automatically go to Children's to do cardiac surgery? Just to follow up on John's questions, how did you get into cardiac surgery for pediatrics?
Well, this suggests a couple of things for discussion. One of them is I wanted to have privileges to operate at the Children's Hospital. And so I went to see Dr. Weech, who was the chief of the whole operation at Children's Hospital, and told him gave him my credentials and described my background, and asked him if I could join the staff at Children's. So that was really my introduction to Children's Hospital. It was through Dr. Weech's approval. Whether there's anything else going on behind the scenes, I don't know, but I should imagine that Dr. Weech called Dr. Carter to verify what I said about my training, but beyond that, I don't know. The thing that bears on this somewhat is that about this time, Robert Gross was successful in closing a patent ductus. I don't remember the year exactly, but the closure of patent ductus was a big thoracic vascular operation in those days, and I was suitably impressed with it. During my internship, I know that the thoracic surgeon on the staff at the University of Pennsylvania found it a very difficult operation to do. Dr. Gross, however, did it with skill. It was not hazardous for the patient. And not long after that, of course, he reported on the treatment of coarctation of the aorta, which again was a serious deformity for which operation or correction had never been seriously considered, certainly not by the pediatrics part of the staff. Then too, Dr. Blaylock reported what is called the Blaylock operation, and really should be called the Blaylock-Taussig operation. It was reported, I think, around 1942 or 43. And this was a revolutionary approach to the problem of cyanotic heart disease, and the specific problem presented by babies and children who had tetralogy of Fallot. Interestingly, the gossip always was that Dr. Taussig didn't meet with any success when she went up to see Dr. Gross. She told Dr. Gross what she thought would be accomplished by anastomosing the subclavian to the pulmonary artery, and Dr. Gross thought that was wild. He couldn't see it. And described Dr. Tausig's ideas as just being crazy. Dr. Tausig, the gossip is, came back to Baltimore and talked about Dr. Blaylock about it, and he thought it might be worth a try, and of course it proved wonderfully successful in the way of helping these blue babies and blue children. And Dr. Blaylock's clinic was soon overloaded with cyanotic children waiting to have the Blaylock operation, which I emphasize was Dr. Tausig's idea, really. It should be the Blaylock-Tausig operation. I don't know whether it's used anymore or not, because surgery has advanced so that it may be that the surgeon is able directly to correct this abnormality and no longer depends upon the palliative procedure.
Mm-hmm.
How did that then get accepted by the pediatricians here?
Well, you know, the dynamics of that, I think, are bring us to a discussion of Sam Kaplan. Sam Kaplan grew up in Johannesburg and had his first part of his medical education down there. He stayed on the staff of the medical school in the Department of Physiology for at least a year. Then he went to England and was a registrar under Paul Wood, who was an Australian, but he had been brought to London because of his skill, his knowledge of cardiology. And Sam had a year or two, I don't know how long, with Paul Wood, and then Ashley Weech felt that the cardiology division of Children's Hospital should be strengthened somewhat, so he arranged for Sam to come to Children's Hospital. Well, with Sam's background and with his personality of absolute assurance, absolute confidence, a child would be presented to him who had a patent ductus, and Sam would say, well, you know, we have an operation for patent ductus, and that's what should be done for this child. Well, the pediatricians just accepted that as the way to go. Mm-hmm. And the same would be true for a child who is deeply cyanotic, who was shown to have tetralogy of Fallot. And Sam would say, well, you know, the palliative operation for that is very good. There's no reason why this child shouldn't have it. Pediatricians would just fall in line after what Sam would say because of Sam's well-established background in cardiology. Mm-hmm. Cardiology, not pediatrics, but cardiology. Right. But the pediatricians were ready for guidance in that direction.
Now, you and Sam got a call from a doctor at the Fels Institute in Antioch, Ohio.
Well, that came through Ashley Weech, actually, but the Fels Institute, on the staff at the Fels Institute were several doctors who were working on a heart-lung machine. They spoke of it as an artificial oxygenator. They were working on it, and their chief, whose name, the Fels Institute chief, whose name I don't recall now, said to Dr. Weech told me this, said to Dr. Weech, I've got a couple fellows up here who are working on artificial oxygenation, and they've carried it as far as they can. They need to connect it to an animal to see if it works, but they don't know how to do that. And I said, well, I think I could connect some tubes to a dog, and the blood would go through it, and we'd see if it would be oxygenated. So that was the start of it. Through Dr. Weech, basically. Mm-hmm. Through these two fellows at Fels Institute who had done a lot of work out in the garage of the Fels Institute on this artificial oxygenator.
And that was Dr. Clark and Frank Golan?
That's right, Lee Clark and Frank Golan. Lee Clark was chairman of biochemistry division, or department, I guess you could say, up at the Fels Institute. And Frank Golan was a physiologist who had been trained in Central Europe. And I don't know more than that. He was on the staff at the Fels Institute.
I think you mentioned a lady by the name of Molly.
Oh, yes, yes. Well, it would be unfair for me to say more about Sam without mentioning Molly. Molly's name was Molly Mackenzie, and she was a nurse on the staff in the hospital in Johannesburg, which is where Molly and Sam met. Molly eventually went to London, and then eventually came to Cincinnati, and eventually Sam and Molly were married. Well, Molly was a worker, so that when we got these materials together, which might be an artificial lung, an artificial oxygenator, we needed help to clean up the mess after the blood had been circulated through it and the dog had been sacrificed and all that. And Molly was right there to do it. She was a whiz, so that she was washing the tubing and washing the surgical instruments and cleaning up the metal parts of the heart-lung machine. We couldn't have done it without her.
Mm-hmm.
Just a wonderful, wonderful worker. As I say, Molly and Sam were happily married, and it worked out just fine.
And I think you said that Dr. Clark, and I mentioned to you before that we do have one of the prototypes of that machine here in the center. He changed the design every week?
Oh, yes, he did. Yes, he did. Well, we carried out the initial experiments in the garage at Fels Institute. That was the importance that the Fels Institute attached to it. They put us in the garage. We carried out the experiments up there. Sam and I would go to Yellow Springs Friday night, and we would do an experiment then on Saturday and on Sunday. Saturday and on Sunday morning, and then clean up and come back to Cincinnati. After a while on that schedule, we decided to move the experimental work down to the research foundation at Children's, and we started there at the basement level where Dick Wolf eventually had his department. Mm-hmm. Later on, we got better space.
So when did you actually do your first cardiac cases at Children's? Was that in the early 50s or?
No, that was, I'm not sure about that. George Benzing would be able to tell us, or maybe I could dig it out of the records, but I think it was around 1956.
About 56?
I think so.
Mm-hmm.
Yeah.
And when you were starting up the cardiac service at Children's, did you run into any problems? Either political, financial, or otherwise. Sometimes people don't like new things.
We had some problems. One of them, I suppose the main problem, was related to patient care following the operation. It's my impression that the nurses were afraid of these patients. They were frightened when they were told that they were coming from the operating room, there would be a patient who's had a heart operation. That frightened the nursing staff. And on one or two occasions, I remember with operations for coarctation or for closure of patent ductus, which is really not much of a procedure, I remember being told Sunday night that my operation for Monday morning had been canceled. And I tried to find out why it was canceled. It was canceled by the nursing office. And their reason was that they felt they didn't have an adequate number of nurses to take care of this patient post-operatively. So they canceled the operation.
I can imagine how the words you may have said.
Well, you know, but the problem, that's why I've said the problem was one in which I think the nurses were afraid. They didn't know what this little body was, what problems this little body was going to present in the way of airway or bleeding maybe, or arrhythmia maybe, or blood pressure changes maybe. It was, well, it wasn't part of their training, you know. So we eventually were able to assemble a group of older nurses, older in the sense of nurses who'd had broader experience and able to establish a kind of a cardiac unit. It was somewhat independent from the nursing unit, from the nursing department in the hospital, but we were able to recruit nurses independently to work in the cardiac unit and to take care of these patients in the early post-op period, certainly for 3 or 4 days after the operation.
Well, Dr. Helmsworth, you mentioned just a moment ago that you took a trip back to Yellow Springs a few years ago to look for your old lab, the garage. What was your finding?
I think that we were successful in finding the student, the commons. I think it's an area where we used to eat dinner Friday night when we went up to start work late Friday night and early Saturday morning. We could find that area, but I wasn't sure about the institute itself, the Fells building, and I certainly couldn't find the garage that we worked in. The garage was not continuous with the building. It was a detached area, but I couldn't find it. Yeah. And I couldn't find anyone to be helpful on it. The campus was pretty sleepy at that time. It was slowed down or maybe inactive.
Don, did you have another question?
Not about that.
Okay. Well, Dr. Helmsworth, you certainly did a lot of cardiovascular cases at Children's, and probably one of the most difficult that you did was a pediatric heart transplant in 1969. John, you were there, and maybe you can tell us the planning and the decision-making process that to take that really giant leap, surgical leap.
The cardiac transplant had been done in Johannesburg perhaps a year and a half or 2 years before. And I remember talking to Sam Kaplan about it and saying, and asking, do you think this development in the field of surgery has any application in pediatric, in the treatment of diseases at the pediatric age level? And I got the impression from him at that time that he thought it did have application. He was it seemed to me more willing to accept the idea than I was. It wasn't obvious to me. But he said he thought it did have application. Well, then of course, cardiac transplantation, the transplants of the heart were picked up at several surgical centers, certainly down in, certainly by Denton Cooley and perhaps by Dr. DeBakey, I don't remember that. But they were being carried out with success on adults here in the U.S. And the matter of controlling rejection was still not under control. People recognized it as the problem, but its control was, it was impossible to control it. During this period, we were taking care of a patient at Children's Hospital, a little girl whose name is not important to us now, though it's clear in my head. This little girl had tricuspid atresia and hypoplastic right ventricle, so that the heart, the anatomical structures from the superior and inferior cava on into the right heart, they just were not there. Mm-hmm. Physiologically, they weren't there. And she was having episodes of distress. I don't know exactly what they were. I guess she was becoming hypercyanotic, and her parents thought that she was having pain. This brought her to the attention of the cardiologists, and Sam wanted to consider her for a transplant, really for a hypoplastic right ventricle and pulmonary atresia. There isn't anything else you could do. There was no way of restoring a right ventricle. So she was considered at the cardiac conference, and it was agreed that a transplant would be an effort at transplanting would be appropriate for this child, and that's where it stood. I don't remember what the interval was, but we were notified that a heart had become available, a heart from a child of the correct age range, and therefore a heart of approximately the correct size, and we decided to do it. I guess I've omitted one important step, and that is that we went through the exercise of cardiac transplantation a good many times experimentally in the laboratory. So we knew what we were going. We knew in detail what we were going to do. It wasn't so overwhelming technically when we were presented then with a suitable donor. Mm-hmm. I don't know more than that about the donor. I believe his heart became available after a severe accident of some kind. We, contrary to the practices of other people at that time, we attempted to perfuse this heart with blood while we were going through its removal from the donor to its placement in the recipient. We tried to maintain coronary circulation, thinking that this would be the best method of preservation of function of the muscle. I don't know what the temperature of the heart was, and of course nowadays the focus is on the induction of profound hypothermia, I guess, in the donor heart.
Mm-hmm.
But our focus was on the preservation of coronary circulation, and whether that accomplished much or not, we'll never know. But we put the heart in, and it functioned. The blood pressure that the child had after we separated her circulation from the heart-lung machine, her blood pressure was low. So we started to give her one of the pharmacologic agents to support the blood pressure, to bring it up. And over a matter of I think 4 hours, her pressure improved a great deal, and it wasn't long after that that she was able to maintain her pressure without the pharmacologic agents. And then she was ready for transfer back to the pediatric cardiac unit, and from there on she did very well until rejection. The process of rejection started, and there we had we lost control entirely. Our steroid replacement was totally inadequate, and the child died.
And I understand that they're still doing pediatric transplants at children's heart transplants.
I think they are.
Yeah.
I think they are. I get the bulletins from the hospital, but I don't go there anymore. But I notice from the bulletins that they have an active program.
Right.
Well, Dr. Helmsworth, I think it'd be safe to say that most of us over the years have had someone or several people that have been mentors in our life, has given us wise counsel or advice that led us to where we've ended up. Is there anyone particular, a person or more, that was very influential in your career?
I can't trace my career back to medical school or even internship and make any comments along that line. I was very impressed by the fellow who taught anatomy, and when I was a freshman. I was impressed by the conciseness of his description of the anatomical detail that we were talking about, that we were discussing. I can remember his discussion of the facial nerve, for example, and how accurately and with what precision he described the origin and the distribution of the nerve. And this made an impression that lasted. As an intern, I met a few people, certainly the chief in neurosurgery impressed me with his considerable skill as a technician, and also in the area of diagnostics, a brilliant guy. The person who influenced me mostly during my training at the General Hospital, I believe, was Dr. Gene Stevenson. Dr. Stevenson was a brilliant fellow, though his brilliance was not immediately apparent to the casual acquaintance. He reasoned very carefully, and he reasoned with accuracy and understanding of surgical details, surgical principles. And as a technician, he had no one could perform the operation for repair of cleft palate nearly as well as Gene Stevenson could. Various comparisons were made on the old 4 East surgical ward at the Children's Hospital, comparisons of the palate and lip repair by one surgeon and the palate and lip repair by Gene Stevenson. And what a difference there was. He was a master.
Mm-hmm.
So I think that covers it pretty well. I would say Gene had more influence on me than any other person in the department.
John, did you have any other questions?
I can't think of any at the moment, but of course they all come later.
They come later.
I wanted to mention one other thing,
Sure.
and that is the blood bank and Paul Hawksworth.
Oh, sure.
You know, this is going back to '41, and I was a junior resident at the Holmes Hospital in the summertime of '41. And to give blood to a patient, we would check the blood type, and then I know I was the right type for someone. I would go down to the second floor, and they would put me in a room and lay me out on a table and put a big cannula into my arm and drain off 500 cc into an open cylinder. And all the time stirring that cylinder to keep the citrate mixture going into the blood, stirring it with a glass rod. Mm-hmm. And then they would take that blood and run it through a filter into a glass cylinder, from which led a rubber tube to a needle in the recipient's arm. And that was a blood transfusion, you know. Well, Paul Hawksworth, who was a resident in 1940, chief resident in 1940, didn't think this was a good way to do it at all. And Paul and Nancy, his wife, developed the idea of collecting blood in aseptic, closed containers and storing it until it was required by a patient. So this was a fairly new idea. I can't say, I don't know that it was original, but certainly there weren't blood banks throughout the United States. The Red Cross may have had a blood bank in Chicago, and there may have been one in New York, I'm not sure. But Paul was really at the forefront in thinking about this. And Dr. Reed must have been too, because Dr. Reed supported him well as he could, I guess, because he gave him the basement level of the old B building. And they set up an office and a blood bank in the basement level of the B building. And Nancy set up the record system, and Paul worked very hard to recruit donors, and in a few years there was a blood bank established with a good inventory of blood of the different types available to the medical service or the surgical service for patients of that type who needed it. It's hard to realize that Hawksworth building that you drive by every day goes back to these very humble beginnings of Nancy and Paul working together down in the basement of the C building. I said B, that's incorrect. It was a C building. Very humble.
Oh, Dr. Hawksworth, as we all know, was quite a guy.
Oh, man.
Well, you required some special instrumentation as time went on. Did you have anybody around that you could take ideas to that could make a special surgical instrument that you needed?
Well, I hadn't thought about that, John. There was a fellow who, and there was an instrument shop in the administration building down at the basement level, and his name was Joe. Maybe it'll come to me later. And he would modify instruments, or he could even carry out, I guess he could carry out the development of an original idea. The instruments that really made a world of difference at one time in the practice of vascular surgery and cardiovascular surgery were the Potts clamps. And Potts, of course, was a chief surgeon at the Children's Hospital in Chicago. He engaged an instrument maker whose name may come to me later, who with Potts developed the Potts clamp. I don't know whether the Potts clamp is very popular nowadays or not, but I can tell you that when we were turning down the subclavian artery to approximate it to the side of the pulmonary artery, the Potts clamp was absolutely crucial. It held that vessel so that it wouldn't slip, it wouldn't retract, and you had a stable operative field here for an anastomosis on a little vessel, 6/0 is what we used, very fine suture material.
I think the Potts clamps are still around.
Are they?
I think so. Well, Dr. Helmsworth, before we wrap up this afternoon, you have 3 children, is that correct?
Yes, I do. Yes, I have a son and 2 daughters.
And your son is a surgeon?
My son is a general surgeon who practices in Muscatine, an area that John knows about, a rural area. He's a general surgeon in a community hospital.
And do you have any grandchildren?
Oh, I have 9 grandchildren.
Oh.
Yes, I have 9 grandchildren and 1 great-grandchildren.
Oh.
Now, I have a grandson who's in training in pediatric cardiology in Southern California.
Oh, that's wonderful.
But the other grandchildren are non-medical people, yes. Yeah. 2 fine daughters and 1 fine son.
That's wonderful.
Yeah.
John, any other questions? We don't want to, Dr. Helmsworth probably got to go somewhere.
That's a comment. It's been a great pleasure to be here and hear you review a lot of these events, some of which I had some personal contact with.
Thank you, John.
In so doing, you became a principal mentor of mine.
Thank you.
I'm going to take a moment to read a paragraph from a letter I got the other day. This is from Dr. Jay Selly, who you may remember.
Oh, yes, I remember, Jay.
He said, "Please tell Dr. Helmsworth that I so admire him as a true gentleman and doctor. He taught me by example how to care for patients and families as people. Hopefully I've passed on that quality to my residents. He also endorsed me for membership in the, I can't read Jay's writing, he was never very good at writing, and I appreciate that, but you must have, AATS, is that?
American Association for Thoracic Surgery.
Well, he remembers that, and he wanted to send those words to you.
Well, that's kind. Thank you.
Well, thank you very much for coming, Dr. Helmsworth, and John, thank you for arranging all of this. And I hope that our audience enjoyed today's presentation.